And so I'm just going to do a quick introduction. Oh, we've got some slides being shared here. So we've got Pinki who's going to come and talk to us today about preterm birth, about Prem birth and the consequences of that. I wanted to give everybody a really quick update while I'm thinking about it before we start, is that we've had some updates from speech and language. We had those in last week come to talk to us. We've had some updates, and what they want us to tell everybody is to remember that you do have to have done some evidence of the graduated approach before you do a referral for them. They're now saying they're going to be much stricter on this, and they want 12 weeks, evidence of 12 weeks of the graduated approach before they're going to accept referrals. So that can be your SEND support plans that you do anyway. So they're wanting 12 weeks. Right, sorry about that, Pinki. We just had to do that update because otherwise speech and language will shout at me because I did promise them I would. So I'm going to introduce Pinki. What are you, a neonatal consultant? Is that correct? So she's going to talk to us a little bit about the impact of Prem birth. I'll stop talking and leave you to it. Off you go.
Thank you, Jane, for the introduction. I'll just share my slides and hope you all can see it moving as well. Can you see it moving? Can you see it moving?
Sorry, yes, we can see it changing slides.
Yeah. Wonderful. So thank you, Jane, for inviting me to this talk. And that talk happens to be straight after the World Prematurity Day, which we celebrated yesterday. So good timing for the talk. And in the next 45 minutes or so, I'll be talking about mainly about the definitions of prematurity and what do we mean by outcomes of prematurity. And then we will talk about the outcomes of extreme prematurity mainly, followed by the outcomes of moderate and late preterms as well. I'm happy to take questions as we go along, so feel free to disturb me if you want any clarification on any of the slides. Otherwise, we'll take questions in the end as well. So in terms of definitions, first, what do we mean by premature birth? So anyone born less than 37-week gestation is termed preterm. However, there are different category of preterm births. So late preterm is around 34 to 36 weeks. Moderate preterm is 32 to 33 plus 6 weeks. Very preterm, anyone less than 32 weeks. And extremely preterm is less than 28 weeks. And when we talk about borderline gestations of viability, which I'll touch base a bit more upon later slides, anyone less than 26 weeks is usually called borderline gestation of viability. And the birth weight categories, again, low birth weight, anyone less than 2.5 kilos, very low birth weight, anyone less than 1.5 kilos, and extremely low birth weight is less than a kilo. And these definitions are important because the future prognostication is based on how preterm were you and what was your birth weight at the time of delivery. So what do we mean by outcome? Outcome in general means any end result or a consequence. Now, when we talk about prematurity, what outcomes are we talking about? And we can possibly divide into two broad categories. So short-term outcomes.
Sorry, somebody's not muted. Could you mute yourselves, please?
So we can talk about short-term outcomes and the long-term outcomes. And when we talk about short-term outcomes, the first thing comes to our mind is survival at the time of discharge from the hospital. And also, what problems did the baby have in the hospital? For example, chronic lung disease, abnormal head scan findings, retinopathy of prematurity, which happens in the eyes of the preterm babies, and something called NEC, which is necrotizing enterocolitis, which affects the preterm intestines. And I'll touch base on all of these in a minute. And when we talk about long-term outcomes, we mainly talk about neurodevelopmental outcomes. What is the baby going to be long-term in terms of their behaviors, in terms of their cognitive function, and also in terms of their long-term health problems related to their growth, related to their gastrointestinal system, related to their cardiac health and the lung health. So first and foremost, the survival at discharge, that is what comes to our mind when we talk about prematurity. And we all read these media reports, which looks like a success story for all these preterm babies who are born very early, born very small, and they go home to their delighted parents. This never ends, and the gestation keeps pushing backwards. This is born at 21 week and 5 days, goes home to her delighted parents. But is survival alone the true success story? Is that enough? Is that the whole truth? And that is where my lecture will focus on. I don't know how many of you have read this book by Jane Rucker, Standing Up for James. If you haven't, it's worth a read. I have got some excerpts from that book, and I'll let you read it through. I'll not talk during this time. This was a story of a solicitor who had a 25-week premature infant who had autism and a severe developmental delay. And it gives some insight into the problems these preterm babies face. I don't know how many of you have watched this documentary on ITV. If not, I'll just play a small clip from this. I hope it shares well.
Baby is about to be born. She's 4 months early. At 23 weeks gestation, below the limits of abortion, the baby will be right on the edge of life. A week earlier, she'd be considered a miscarriage and left to die. A week later, everything would be done to keep her alive. But what's the right thing to do for her?
I don't think I would want my baby at 23 weeks resuscitated, because I know what it involves for the baby and the outcomes being so poor. And in the end result may be a child who's severely disabled and potentially has a very poor quality of life.
The trouble is that 90% of these babies die before they leave hospital. And of those that survive, most will be disabled. 21-year-old Heather was born in extreme prematurity. She's quadriplegic and needs carers for even the simplest of human needs.
Is this as far as my life's gonna go? There's obviously nothing else out there for me. So what's the point, really?
We started to end my life, really.
I'll stop it there. So sorry to start on a depressing note, but this was about extreme preterm infants born at borderline gestation survivability. And we are pushing the gestation further and further. Can I ask the audience, what gestation do you think the national recommended gestation that we have to be present for a baby's resuscitation? Any guesses? So this is our national body is British Association of Perinatal Medicine, and this is an excerpt from 2008. This is their framework for management of babies born extremely preterm at less than 26 weeks of gestation. And at that time, around 16 years ago, Anyone less than 23 weeks, we never resuscitated the baby, And between 23 to 26 weeks, we would go to the delivery suite and we'll see the condition of the baby. And if we think baby is not going to do well, we'll possibly not resuscitate, but we can give it a go if parents are keen and we think they are favorable prognostic factors. This was around 2008, and we used to regularly resuscitate babies from 24-week onwards. However, in those 16 years, life has changed around the world. This is the published data from 2011, survival rates of hospital discharge from 22 to 25 week gestation. Sorry, a busy slide, but all you need to concentrate here is Japan reported increasing survival of babies at 22-week gestation. And then came a Swedish paper. This blue line is a 26-weeker showing increased survival from 1985 to 2016. Then the yellow line is the 25-weeker survival, and you can see it's increasing to around 90%. Good work. The gray line is the 24-weeker survival in those 40 years. And then the orange line is the 23-weeker. And then a dark blue line appears of the 22-weekers. And as you can see, the 22-weeker survival is approaching around 50% in Sweden. So obviously the UK had to join the race. And here came another guidance in 2019, an updated guidance where they decreased the threshold of gestation when we can resuscitate babies from 23 to 22 weeks. So now we are not resuscitating babies at 21 plus 6 weeks, but anyone from more than 22 weeks, we are having a discussion with parents whether or not they want resuscitation based on a risk assessment. So if the gestation of the baby is beginning of the weeks at 22 plus 1, if the weight is not very good, if it's a male infant, if they are twin pregnancy, these are extremely high risk and we can decide against resuscitation in agreement with the parents. However, if parents wish, we may have to perform resuscitation on these babies. And this is the framework which the national body has given us. So the 22 weeks, 7 in 10 babies die, and of those who survive, 1 in 3 babies will have severe disability. Now it says 1 in 3 babies will have severe disability. The remaining 2 may have mild to moderate disability. And the death rate decreases as the gestation advances, and the same with the neurodevelopmental impairment. So the later you are born, your chances of having neurodevelopmental impairment is less. Now, saying that at 22 weeks in the last year, since that guidance came out in 2019, in the last 5 years, we've had no survivors at 22 week gestation from the West Midlands. The prematurity is a significant burden of neonatal mortality. A third of all infant deaths happen because of prematurity. 45% of children with CP are premature, and a significant proportion of those who have developmental delay, vision impairment, and hearing impairment have prematurity. And this is, again, I have already said, each day in the womb counts. So the earlier you're born, the less your chances of survival. So on the left-hand side, you can see the survival figures increase as the gestation advances. On the right-hand side, you can see the long-term impairment. So the earlier you're born, the less chances you have to survive, but those who survive have a significantly high chance of having long-term neurodevelopmental impairment. And why does this happen? Now, this can be demonstrated by this diagram. You can see the brain of a 25-week and the convoluted brain of a term baby. If a baby is born at 25 weeks, this brain is going to get exposed to significant periods of, lack of oxygen, infection, inflammation, lack of proper nutrition, inappropriate stimuli of light, noise, and a lot of unfavorable environment, which is not there in utero in the womb. So this brain is not going to develop as well as if the baby was remained in the womb. This is the preterm lung. You can see how the lung developmental happens. And if you compare the lung of a 24 to 35 week gestational age to a term infant, you can see that if the baby is born at 24 weeks and then ventilated, these alveoli get damaged significantly, leading to what we call bronchopulmonary dysplasia or chronic lung disease. And you can compare the size of the alveoli to that of the preterm alveoli, and these are quite damaged and small in number and small in area. And that is going to have a significant impact on their long-term lung health. And this means that a number of our babies go home on oxygen for at least for 2-3 months, especially if they're born very early. Because of this increased oxygen need, these babies also develop what we call retinopathy of prematurity. This is how the normal retinal blood vessels look like. However, if the oxygen is given to a preterm baby, it gives a stimulus for vessel growth, especially in the retina, which then can cause retinal bleeding and retinal detachment, leading to poor vision later on and visual impairment. Also, preterm babies' intestines are quite immature, and they sometimes have a condition called necrotizing enterocolitis, which is mainly seen in preterm infants and presents with abdominal distension, bloody diarrhea, perforation, and some of these babies then end up having a surgery and a stoma, which is later reversed depending on the health of the gut. Some of these babies end up with a short gut syndrome and may remain on long-term parenteral nutrition. So just going to talk about epicure studies. These were studies done in England, in the whole of England, about the preterm birth, especially focusing on 23 to 26 weeks gestation babies. And the first epicure study was done in 95, and the second one was done in 2006. And between the 11 years, you can see the number of preterm births between 23 to 26 weeks gestation nearly doubled. And if we have to run a study now, it would have been significantly doubled now that the gestation of resuscitation has been lowered further. And this is what the Epicure study in 2006 showed. You know, the survival figures are on the top. At 23 weeks, around 16% of the babies survived. And of those survived, you can see that only around a third had no disability or mild disability. The yellow is a moderate disability and the red is a severe disability. And as you go advance the gestation, your rate of disability decreases and your rate of survival increases. And these figures are slightly better in 2024, but still the proportional disability is still present in our 22 to 26 weeks infants. Now, how do we predict outcome in these babies? And there are a number of parameters we'll look at. For example, this is a US database. And at the time of birth, you can possibly guesstimate what this baby's chances are for having long-term neurodevelopmental impairment. And the 5 key things that we need at the time of birth is what is the gestational age? That is the biggest deciding factor of baby's long-term neurodevelopmental impairment. Then the birth weight. Then the sex of the baby. Male infants tend to fare worse than the female infants. Singleton birth, if you're a twin gestation or a triplet, your prognosis is slightly worse than if you were born a singleton birth. And if they've had antenatal steroids, the mother have had antenatal steroid or not, that increases your chances of a favorable neurodevelopmental outcome. So you can input that data and it tells you what are your chances of survival. What are your chances of survival with moderate to severe neurodevelopmental impairment? For example, this baby born at 24 weeks, birth weight of 720 grams, was a female infant, has 26% chances of dying and 24% chances or 39% of chances of having death or significant neurodevelopmental impairment. And what are the factors that affect your long-term outcome at the time of discharge from hospital? So that is affected by whether you've had significant chronic lung disease, whether you needed steroids for your lungs, whether you've had necrotizing enterocolitis, whether you had retinopathy of prematurity, how was their growth? Because growth is equally important because that affects not just the body growth, but the brain growth as well. And if you've had any head scan abnormalities, we routinely do head scan in babies. This is a head scan of a baby born preterm, and you can see holes in the brain, which we call periventricular leukomalacia, which is common in preterm babies, leading to a definite diagnosis of cerebral palsy. Again, there is also chances of significant bleed in the brain. The arrows points out to a bleed in the brain. And again, these are very common in babies born less than 30 weeks. And that affects their long-term outcome. So what does NICE recommend? So NICE recommends that anyone born less than 30 weeks gestation should have a developmental surveillance for at least 2 years. And actually NICE says up till 4 years for babies born less than 28 weeks. And anyone born between 30 to 36 weeks should have close developmental surveillance if they've had a brain lesion, if they've had hypoxic ischemic encephalopathy, or if they had a brain infection. And we always correct these infants at least up to 2 years. So, we take them as they were born at due date rather than their actual date of birth. So coming to cerebral palsy, it's inversely related to the gestational age. 6 to 9% of infants who are born less than 32 weeks have cerebral palsy. But the incidence increases significantly to around 1/4 for born less than 26 weeks. And it's inversely proportional to the gestational age. As I mentioned, the earlier you're born, the more you are at risk of cerebral palsy. Now, coming to cognitive outcomes. Now, again, a busy slide, but this is the IQ scores or the cognitive scores. And you can see the term infants here in the comparison group. This is what their IQ looks like. The boys are squares, the girls are circles. And you compare that outcome with a 24-weeker or 25-weeker boy or girl, and you can see the significant drop in their IQ scores compared to their term counterparts. And it becomes more apparent with increasing age. In a study, they found that a preterm infant usually loses around 7 to 16 IQ points versus their term controls. And in the Epicure studies, they found 40% of the children had cognitive problems, significantly in maths and reading, and twice as likely to need special educational input. They have deficits in working memory, in their processing speed, in the visuospatial skills, in attention and executive function. And if you tell a complex task to a preterm infant, it's much better to break it down into sequences rather than telling that in the way we normally say, because they can't process it simultaneously. They are better off doing the process in a sequential manner. 44% of these preterm infants will have serious learning deficit in maths. And this is the difference between a preterm child and a term child in terms of their difference literacy scores, mathematics scores, science scores, geography, history, information technology, everything. You can see that the term counterparts, in comparison, they are far behind. So anything left to the line means it is disadvantageous for the preterm infants. And you can see they are more affected in math, and then in literacy, and then in other subjects. Again, a busy slide, but this paper looked at infants from birth till early adulthood, and they looked at preterm infants less than 26 weeks of gestation. And it says that the blue highlighted area in the results, the mean cognitive scores of extremely preterm infants were on average 25 points below their term-born peers. So not just cognition, it also affects their hearing and language. Sensory neural hearing loss is present in 1 to 4% of preterm population, and they are 10 times more likely to have language problem and hearing problem at 6 years of age. Visual outcomes, as I mentioned, retinopathy of prematurity is becoming increasingly common. 5 to 6 babies with severe visual disability are treated for retinopathy of prematurity. They are commonly having poor visual perception, squints, and refractive errors as part of their prematurity. Coming to behavior and psychology, these preterm babies are less risk-taking. They are less socially adept. They are more likely to have attention deficit hyperactivity disorder, depression, anxiety, and antisocial behavior. And at 11 to 12 years of age, epicure children were 2 to 3-fold at risk of having a psychiatric diagnosis than their controls. Around 1/4 had mental health disorder and autism. That's a significant number. They're high risk of autistic spectrum disorder. Now, this was just about their short-term outcome, short-term neurodevelopmental impairment. What happens on their adult health? Now, very low birth weight infants, that is babies born less than 1.5 kilo, are significantly shorter than their controls, roughly around 4 centimeter for men and 8 centimeter for women. Their bone density is weaker compared to their term counterparts, and they have also got high risk of non-insulin dependent diabetes mellitus in their adult life. What about cardiovascular health? They also have increased risk of hypertension because it's all about neonatal programming of adult health. Your systolic BP will increase progressively with decreasing gestation at birth by 0.31 millimeters for every week in gestation drop. These babies are also at risk of asthma, airway obstruction, and air trapping because of their sequelae of chronic lung disease. And sleep disorders, disordered breathing, and sleep apneas are also more common, twice as more common in very low birth weight infants compared to their term counterparts. What about long-term medical and social consequences? So as I mentioned, cerebral palsy, more common. Mental retardation, 4 times more, this is 10 times more common, the mental retardation. Increased risk of schizophrenia. So a preterm baby will have 0.6% chance of having schizophrenia compared to 0.1% of term babies. Autistic spectrum disorder, very, very common in preterm babies. Other psychological behavior, emotion disorders, again, much more commoner in the preterm babies compared to their term counterparts. Now, this was mainly focusing on extreme preterm infants less than 30-week gestation. We usually forget about the moderately born preterm or the late preterm. Do they have any consequences or do they escape unaffected? Now, a study was done for babies between 32 to 36 weeks gestation. These are moderate to late preterm. They account for a significant proportion of the preterm births, 6 to 7% of all births in the UK and 75% of all preterm births, because most of these preterm births are in that gestation. However, a number of these infants use the hospital with recurrent hospital admission for lung problems or infection or gastrointestinal reasons. Almost twice as compared to their term counterparts. They are 4 times more likely to have a medical condition than their term infants, and mortality rate is 3 times that of the term population. So, okay, they are not as worse off as their counterpart who are born less than 30 weeks, but they are not completely unaffected if they're born early. It does affect your brain, it does affect your lungs, it does affect your intestines to some extent. Again, late preterms, they also have a risk of cerebral palsy, and subtle neurodevelopmental issues are common, poor school performances, as well as behavioral problems. because the brain weight at 34 weeks is only 65% of that at term gestation. Your gyri and sulci are still immature, and that can be affected if you're born early. And respiratory symptoms are much more common in moderate to late preterm infants compared to their term counterparts. Any questions? I don't know whether I pitched at the right level. Is that what you wanted to know, or what but I just thought I'll just give you an oversight of what happens with the extreme preterm gestations. Verity?
That was absolutely, sorry, I didn't realise your question. I was going to say that was absolutely what we needed. It was getting people to understand, the long-term impacts. Was there a question? Was it Verity? Yeah.
You mute Verity.
Yeah, hello. It was really interesting. There was two reasons why I joined this course today. One, because I'm hopefully training to become the SENCO at Little Angels, and this, with regards to my practice, may be useful to know if the children who are in our setting were Prem or extremely Prem, and we also have a child with complex needs in our setting as well that I support to look after as well. So yeah, that was really, I was quite surprised that they don't resuscitate after before with a certain time. And also my son was born at 34 plus 6, so by emergency cesarean, and he is autistic. So I was interested. We had to track his development quite closely for the first couple of years. And even now, we have to keep an eye on what's going on, although he has a chromosome swap as well. So we have to keep an eye on what's going on with what he's doing, or what could be happening with his development. And he's 11, and he's doing really well, bless him. So yeah, it was really interesting. But what my question is as a practitioner, or as a possible SENCO, hopefully in the future, what's appropriate and what's not appropriate to see as a red flag, or can I actually say, oh, this is possibly because he or she was Prem, or does that make sense, or do we leave it to this to deal with?
Good question, Verity. This is what I won't be able to answer, because this is not my area of expertise, that what you can offer. But what I know, that we tend to routinely refer, I think all children who are born less than 28 weeks should be, are referred to community pediatricians and SENCO, so that, we know that these babies will need your input. They might need one-to-one, as I said, they have a lot of cognitive deficit. They can have problems with literacy, math, and they will need one-to-one support to help with, So what strategies you need to adopt is, sequencing the work for them. How basically they need one-to-one attention for them to understand the concept.
Can I say that obviously this is where you then come to us. So what the purpose of this was for you to understand that there could possibly be an impact. The strategies are very much dependent on the child, what the impact was. So the advice is, it's obviously then we need you to understand about Prem birth so that you can ask that question, because I do think that is important. One of the questions I ask when I come in as an area SENCO is, I'll say, is there anything I need to know about this child's past? And one of those things would be, were they born, significantly Prem? And that would impact on my knowledge of the child. But actually the strategies are dependent on the child. It's dependent on what that impact is. So as we've heard, there could be a huge variety of impacts, and that impact would depend on level of the level of need. What we would do would depend on the level of need. It would depend on what the impact has been. So there's lots of people on our team that would be more of an expert to talk about each individual, excuse me, my teeth aren't in today, each individual aspect of what these children would need. But it's very much about us asking the right questions so we can understand why. But it's also dispelling some of those myths around children growing out of it. Because I think certainly I've been around a very long time, and one of the things I used to hear a lot of is, oh, they were prem, but they'll catch up at this age. And many children do. We've looked at the statistics. Some of the children with late prem birth do very well, but there are those children where there's a long-term impact, and I think it's important for us to understand that and to support parents to understand that. Have we got any other questions at the moment? I'm really, really grateful for you coming today and talking through. I don't know if it was you, but many years ago I had this training, and it really did impact my understanding, my knowledge around this. So I'm hoping that for everybody else out there that it's raised a few questions, if nothing else.
So if there is anything that, because obviously we track every child's development in nursery, if there is anything that flags up, then we speak to Anthony and say, and we ask the question, was this child premature, by how many weeks, and maybe this could be something that needs to be followed up, or has there been any paediatrics?
Same as any SEN needs. If a child's got any SEN needs, what you would do is you'd talk to your area SENCO and get advice around what that child would need. If they came with medical needs from being prem, then obviously they would come with those medical diagnoses. And I think very often a lot of the very early children would be referred to the SPY team. I think there's people from the SPY team on, so they would probably already have come with that support, because it would have been noticed from birth, from very young. They would have an awareness if there was a visual impairment, if there was hearing impairment, if there was cerebral palsy. Those children would already be referred.
We already speak with Julie quite closely and work with Julie on a child, so that's great. Brilliant.
Okay.
Sorry, can I just ask a quick question? Sorry, can I ask a question? So we've got a little girl who was 24 weeks when she was born. So the problem I'm having at the minute is I do feel like she has got some communication delays, but do I hold off because she was premature, or do I still go down the route that I would if she wasn't premature, if that makes sense?
That's a very good question, Charlotte. The first question I'll ask you is, do you correct for her prematurity? That's the first question. That means that if she was born in January, her date of birth is January, and now we are in November, she is seemingly 9 months now. But if she was born at 24 weeks, we should be counting her actual age, what we call corrected age, from the time she was supposed to be born. So if her due date might have been in April, so she's only 7 months, for example, and her developmental assessment should be based on as if she was 7 months rather than 11 months, if that makes sense. So at 2 years,
that's what we are doing at the minute. They have got a corrected age from when she was born, but they've told us from when she's 2
so we do so thank you, Charlotte. I do a neurodevelopmental assessment clinic for these preterm babies, and if they are not doing what they're supposed to do at 2, and basically our criteria is that if they are not even saying 5 words at 2 years, we then refer on to speech and language and do a hearing check just to make sure the hearing is optimal for her speech development. So if you think that is significantly delayed, that they are not even saying 5 words at 2 years of age, that is the point I will make a onward referral. But most of these babies should be having a proper developmental assessment at 2 years corrected age by the hospital they were born.
Okay.
and we usually take care of those referrals. But if it hasn't been done, please, some children do slip out of the net. So please do a referral as appropriate if you think this is not normal.
Okay, so is it when she's 2 years corrected age or 2 years from the date of birth?
2 years corrected age, that is when you should look at.
Okay, brilliant. Thank you.
Thanks.
That was a great question, because that was one that I hadn't asked and had thought about. So is there anybody else that's got any questions at the moment? I'm going to ask Anthony. I don't know if you've already done it, but could you put a evaluation in the chat for us?
Yeah, it's all done.
I thought you might have just done that, because Anthony knows that's his job for us. If you can do an evaluation for us, that'd be really great. If anybody has got any last minute quick questions, you want to put them in the chat, we can always do that. The chat stays open for a little bit. So if you think of something afterwards and you want to put something in the chat, and I can get it across to you, Pinky, if that's okay.
Perfect.
But otherwise, I just want to say thank you so much for that. That was great. I'm really grateful for you having done that. It's one of the ones I've been trying to get. Yeah, it's one of the ones I've been trying to get for a while. So I think that's really good. Thank you so much. And after that, everybody else, thank you very much for your time.
Thanks everyone. Nice to be this. Thank you.
I'm hoping people will be popping stuff into evaluations now for us.